Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through asthma in preparation for or as part of the advanced pharmacology course for nurse practitioners. So let's start very basic with a pathophysiology review of what is asthma. Asthma is three problems. Number one is bronchoconstriction. The bronchi and the bronchioles get constricted, they become smaller in size. The second problem is inflammation. The bronchi and bronchioles, also the walls become inflamed. They become swollen, further decreasing the internal diameter of these pathways of the bronchi and the bronchioles. And the third is that the pathways themselves fill up with secretions. These three problems, the constriction, the inflammation, and the secretions, dramatically reduce the amount of air that can move through these airways. So let's talk about diagnostics. So we're talking here about how to diagnose a patient, and this is a little bit beyond what you would be tested on in advanced pharmacology, but really quick. Pulmonary function testing is vital to diagnosing a patient with asthma. FVC is forced vital capacity. That's the total volume of air a patient's lungs can handle, and that's measured by having the patient take a really deep breath and then exhaling everything that they can exhale. FEV1 is the amount that a person can exhale in 1 second. So that's going to be a foundation of diagnosing a patient with asthma. Next, we have a CBC. Obviously, we're going to get a full set of labs. I'm just highlighting the CBC here because we would use that to diagnose and make sure the patient doesn't have anemia or any other problems that would coexist with their asthma that would make it even more difficult for us to get oxygen to each and every cell in the body. Finally, a chest x-ray. While a chest x-ray very clearly is not used to diagnose a patient with asthma, it is absolutely part of the workup for a patient being treated with asthma. This next chart that you have in front of you is called the Asthma Quick Care Reference Guide. It's published by the HNLIB, and it's available on, you could just pull it up on Google. You will be using this as a nurse practitioner when you're managing patients with asthma. This gives us a very clear method of determining whether the patient's asthma is well controlled, not well controlled, or very poorly controlled. And it does this through a list of factors. We check the patient's symptoms, we check their nighttime awakenings, we check if they're having, is this interfering with their daily activities? Are they able to do all their daily activities without any issues? How much are they using their SABA? That's a really big indicator. Are they needing it less than twice a week? Are they using it more than twice a week, but not daily? Or are they using it daily or multiple times per day? All of these help us categorize our patient. It helps us make treatment decisions as a nurse practitioner. We also can make these decisions based on lung function testing and the patient's reported signs and symptoms. So now let's talk about the actual pharmacological treatment of a patient with acute asthma exacerbation. So first we're going to talk acute asthma exacerbation, and then in the next part, we'll get into chronic asthma management. So first and foremost, we're going to give these patients oxygen. If a patient's struggling to breathe, we want to give them oxygen. I do want to make a few notes here. First of all, we don't give a patient oxygen when they have a normal pulse ox and no respiratory distress. We used to, back in the day, let's say a patient was having chest pain, we gave all those patients oxygen. We don't do that anymore. Now it's for either respiratory distress and or a low pulse ox. When we are giving a patient oxygen, this is something that surprisingly a lot of even nurses struggle to fully understand and explain. What is the actual accomplishment of giving a patient oxygen? Let me explain it briefly. When we all take a breath, an average adult, let's say, breathes in 400 to 500 cc's of air, or let's call it mLs of air with every breath. For simple math purposes, let's say 500 cc's of air. When we breathe that air in at room air, 1/5 of that is oxygen. 21% is room air is oxygen. So really, we're breathing in 500 cc's of air just to get that 1/5, in our example, that would be 100 cc's of air that's actually oxygen. The rest of it was pointless, but that's the hand we're dealt. That's the environment we live in on this planet, so that's the way our lungs are designed to breathe. We breathe in 500 cc's of air for 100 of cc's of that, which is oxygen. Obviously, we do have some benefit from the other part of it in terms of it absorbs the CO2 that we exhale, etc. But what is the value of giving a patient oxygen? Very simply, when a patient's having an asthma attack, when they're having trouble breathing, when they're fighting for every cc, every cubic centimeter of air that they're trying to pull into their lungs because their passageways are constricted, are inflamed, are full of secretions, when they're struggling for every drop of air to bring into their lungs, they can't afford this highly inefficient system of breathing in a whole bunch of air, 500 cc's, just for that one little 21% of it that they actually need in order to get oxygen into their body, into their bloodstream, and into every cell in their body. So when we give a patient oxygen, what are we accomplishing? we're making it that all of the air that they breathe is oxygen. So that now, even if they only breathe in 100 cc's of air, since that whole 100 cc's of air is oxygen, it's the equivalent as if they got a full regular normal breath, in our example, 500 cc's of air. So what is the benefit here? By oxygenating the air that the patient's breathing, for example, putting them on a non-breather mask at 15 liters, we are giving the patient a very concentrated dose of oxygen. What's the benefit? That they don't need to bring as much air into their body, that the less amount of air that they are breathing in, that which in their case is all that they could breathe in, they're struggling for every drop. That little bit that they bring in is all they need because we made it highly oxygenated. If they were only breathing a little bit because they're struggling and that little bit was still only 21% oxygen, they'd be in real trouble. So that's the value of oxygen. If that was a refresher, by all means, that's fine. But now, just to make sure you have a good understanding. Moving on next, we have albuterol. That is the foundation of acute asthma management, and we'll talk about extensively on the next slide. So I'm going to skip that one for right now. The next drug we have is ipratropium. This is an anticholinergic. It goes by the brand name Atrovent, and I'm not going to go too deep into this. There's not that much that's beyond the basic RN level that you would have to know probably for most advanced pharmacology courses about this, but I will give you the highlights. Atrovent is an anticholinergic. It's a muscarinic antagonist. What does it do? It does two things. Remember, we said asthma's three problems: bronchoconstriction, inflammation, and secretions. This reduces in secretions. You probably remember that anticholinergics dry things up. So this helps with secretions. Plus, this also significantly helps with bronchodilation. It definitely helps with expanding the arteries. If you think about it, anticholinergic means because cholinergic are the parasympathetic receptors. So anticholinergic can be thought of as anti-parasympathetic. Because it's anti-parasympathetic, what does that make it? A sympathetic drug. What's part of sympathetic? Part of fight or flight? Bronchodilation. So that's how it helps with that. That's the mechanism of action. Not a whole lot beyond the RN level that you'd have to know about that. If you want to refresh on it, we have separate videos at the RN pharmacology level that you can also use as prep for your advanced pharmacology course. Next, we have steroids. We're going to talk about that when we get to the chronic drugs. And then we have magnesium. Magnesium can be given as an IV infusion for patients that are having acute asthma attack. You probably remember that magnesium is a smooth muscle relaxant. So when the smooth muscles around the bronchi are really tight, resulting in constriction, this relaxes the muscles, resulting in dilation. Do remember, especially a good test question, that when a patient is taking magnesium via IV infusion, they always need to be closely monitored for magnesium toxicity. And the way we monitor that is by their respiratory rate and depth. Don't forget that second part, respiratory rate and depth, plus their DTRs or deep-tendon reflexes. Both of those are the two primary continually monitored assessments to determine if the patient's becoming mad toxic, because if we don't recognize that, we could give them so much magnesium that we really relax all their smooth muscles to the point that they stop breathing. So let's go ahead and go a little bit in depth into albuterol. Albuterol, most of this is an RN refresher. Albuterol is a beta-2 adrenergic agonist. You'll remember the sympathetic nervous system, fight or flight, has 5 primary receptors: alpha-1, alpha-2, beta-1, beta-2, beta-3. Beta-2 is responsible for bronchodilation. So by us pressing on the gas, by giving a beta-2 agonist, we are activating beta-2 of the sympathetic adrenergic receptors, and that causes bronchodilation. How does it do it? Basically, like we said it a minute ago, it dilates the smooth muscles around the bronchi. It's not like the bronchi tissue themselves have the ability to dilate or constrict. That's controlled by the smooth muscle around it. So that's how the drug works. It is used for both acute asthma and COPD. It does have a bunch of side effects, which are good test questions to make sure you know them. It can cause tachycardia. I really need to highlight here this: if you have a patient that is having severe respiratory distress and in the acute setting, you put them on continuous nebulized albuterol, they may end up with an increasingly higher heart rate. They may end up 130, 140, 150, and even higher. This may get your nurses pretty excited that, oh my gosh, this patient's heart rate's going so high. Keep in mind, the patient can tolerate a heart rate of 165. They cannot tolerate a pulse ox of 65. This is basics: airway, breathing, then circulation. So if it takes continuous albuterol to get their pulse ox up, because their pulse ox sucks if it's 60, 70, whatever, and even if their heart rate's creeping up there, monitor it, of course, but do not forego their albuterol treatment for the sake of avoiding a heart rate getting high, because airway comes first. So that's tachycardia. It does cause hypokalemia, which is closely related to the fact that it also causes hyperglycemia. you remember pathophysiology, hyperglycemia, when the cells shift all that sugar into when all that sugar shifts into the cells, it takes potassium with it, which is why it causes hypokalemia. Because the tachycardia can also cause palpitations, technically it can also cause a headache, and finally it can cause hypertension. Do keep in mind, especially some of your textbooks may tell you that you should use this cautiously in patients that have underlying cardiac conditions, because in those patients, it does get a little dicey to overexert the heart, especially like we said, if we have to do this continuously and get their heart rate pretty high, and that puts a lot of strain on the heart. But again, it becomes a risk versus reward. What can the patient tolerate better? The high heart rate, given that they have underlying medical conditions, or a really low pulse ox. So you have to make that decision using some guidance and what you feel, using some of your judgment, your critical thinking, and what's best for the patient. Every single patient who is prescribed an albuterol inhaler must be educated on that. That falls on you as the provider. If you delegate that to the nurse, that's fine, but you must make sure that patient is educated. There are some great videos on YouTube. Pretty much every children's hospital has a video on how to use an inhaler. Whether your patient's a pediatric or an adult, doesn't matter, other than that if it's pediatric, you need to educate both the kid and the parent and make sure they know how to use it. Also, as the nurse practitioner, make sure you're giving the patient extra inhalers. If it's a kid, give them one for their backpack, give them one for their house, give them one for the school nurse. Ask them if they can think of another place that they need it at. If it's an adult, educate them. They need one for work, one for their office, whatever it is. Do keep in mind, especially depending on the climate you live in and the time of year, it's not generally a good idea to keep it in your car, because cars get very hot or very cold depending on the climate and the season, which may cause a problem with the efficacy of the medication if you leave the inhaler in there. Albuterol is absolutely the first-line drug that we give for patients for both acute and chronic asthma. We'll talk about chronic in just a minute, but for acute asthma, this is definitely the go-to. Also, keep in mind, we want to educate patients when they're prescribed this, when they're newly diagnosed with asthma, that they should be using this as soon as they feel that they're about to end up in trouble. Don't wait. Don't try to suck it up or hold it out. As soon as you feel the asthma attack coming on, go ahead and take your medication. Next, we also want to educate patients on exercise-induced asthma. This is used preventatively in cases of exercise-induced asthma. If a patient has that diagnosis, they should be educated to take this medication at a specified period of time before their strenuous activity that causes them to have an asthma exacerbation. Finally, albuterol does come in both nebulizer and MDI. Both are used in the acute setting. Both are used in the at-home setting. Obviously, most commonly, the inhalers are for the house and the nebulizers are for the acute care setting, but that's not a hard and fast rule. When you're prescribing this, take into consideration which one's best for your patient. Obviously, the rule of thumb is that in the acute setting, we use nebulizer, and for patients to just have on an outpatient basis, we use the MDI, but we do have exceptions in both ways. When you're giving this, and you may get tested on this for your class, consider the compliance, the cost, the side effects, the accessibility, and the delivery of the medication. Next, we have our assessment. We're moving now on to the chronic management of a patient that has asthma, and technically almost all of this goes for COPD as well. We have 6 level steps of where a patient can fall. This is from the same guidebook that I posted a few slides ago. This is the Asthma Quick Care Reference Guide published by the NHLBI. And it gives us 6 steps of the severity of a patient's asthma. Step 1 is intermittent asthma. That's great. They get their symptoms once in a while, less than 2 times a week or so. They go ahead, they take their PRN inhaler, they're good to go, and that's it. Then we go up to where a patient has more significant symptoms, where it's occurring several times a week or even several times a day. So from there, we start to put the patient on a daily medication. Remember, the SABA PRN is more of a reactive strategy versus putting them on a daily medication is more of a proactive strategy. So we start with a low-dose ICS. That is the universally accepted first-line drug choice for a patient with chronic asthma. To manage it pharmacologically, we put them on a low-dose ICS. Remember, this is always in addition to that first step of the rescue inhaler. Low-dose ICS, we're going to talk about extensively on the next slide, so I'll put a pin in that for now. From there, if that's not enough, and it's based on the symptomology and the assessments that we talked about a few slides ago, where we classify as the patient's asthma well-controlled, not well-controlled, we could either bump up the dose of the ICS, or we could add on a LABA. That's a really common choice. Symbicort is a combination between ICS and a LABA, one of the really popular ones, and there's many others out there as well. Or like I said, we just bump up the ICS dose. Moving on to step 4, you guys can see this for yourselves, medium dose ICS and a LABA, and then we can move on to a high dose ICS and a LABA. There are monoclonal antibodies out there. This is an injection medication, as I'm sure you're familiar with by now. The one over here is called omalizumab. I'm not going to get into this. If your course is covering this, I'll let you look it up yourself. But omalizumab is a drug that is used specifically for allergen-induced asthma. It's a monoclonal antibody. So if you're familiar with monoclonal antibodies, that means it's an injection. That means it takes several months to work. That means it's teratogenic and immunosuppressive and expensive and all of that. You'll notice step 6, the very last chart, the very last box all the way to the right. This is where the patient with all of our treatments is still not having their asthma symptoms well controlled. And in that case, we do end up at oral systemic corticosteroids, hopefully just short-term, not long-term. We do know there's a lot of adverse effects of that. We've learned steroids in previous videos, and we'll learn about inhaled corticosteroids in just a minute. But these oral corticosteroids, that's our last resort. That's if we need to end up there, just like we had with acute. Okay, so for acute, we had the systemic, the oral, or the IV corticosteroids. Here too at step 6, we have that again. Everywhere else, we would not want to use systemic steroids, again, because the tremendous number of adverse effects that come with it. Obviously, for short term, it does have tremendous value if that's appropriate. But keep in mind, we only use it for acute or step 6, which can basically end up being acute. We don't generally use it other than that. There are a few other medications here that we'll talk about in just a little bit as far as the other options for the treatment of chronic asthma. So right now we're going to spend just a few minutes talking about inhaled corticosteroids. This is the universally accepted first-line treatment when we're going to a daily medication. The medications we're talking about here are fluticasone, beclomethasone, budesonide. These are dosed in puffs per day. Usually we start with 2 puffs in the morning, 2 puffs at night. That's a pretty standard dose, and that's what the patient takes. This is the first-line medication for chronic asthma. Patients do need to be educated. They must rinse their mouth out after using it, or else they can get oral candidiasis, also known as thrush. Keep in mind, patients must understand this absolutely will not help them as a rescue inhaler. This does not provide acute relief. This takes several days to several weeks until it actually has its full effect. So this is not something they should confuse with their rescue medication. I do want to spend a second here. There is a debate about whether or not steroids, specifically inhaled corticosteroids in pediatrics that have asthma, if it stunts their growth. There is evidence that supports the fact that intermittently, while they're on treatment, it does slightly reduce their normal growth. However, the general consensus, and I'm not giving this as a for sure fact, but the general consensus is that the long term, there are no ramifications in terms of negative effects of growth on kids taking long-term inhaled corticosteroids. Oral steroids, absolutely, and we're not discussing that today. We said that that was on the list for the acute. We said that was on the list for step 6, but that's not what we're talking about right now. The inhaled corticosteroids, the ICSs, there's no solid evidence that I'm aware of that currently says that there's long-term detrimental effects to a child's developmental growth. Based on this, there is some discussion about it, but generally the consensus is that that's short-term only. What are some other options that we have? Let's talk just for a minute here. And again, for most of these drugs, I don't have a lot to add to what's taught at the RN level, so we're just going to go through it quickly, and you can refer back to the bullet point nursing video at the RN level to familiarize yourself with this. LABAs, that's salmeterol, formoterol, very, very commonly used. Like I said, Symbicort is one of them. Not that I have any stake or any conflicts of interest there. It's just the first one that comes to mind. We also, when we're giving LABAs, keep in mind it's never given by itself. In fact, the black box warning says that it's not to be used as monotherapy. We have LTRAs, which is montelukast. The plus side there is it's a pill. It's not an inhaled. So that's a plus to patients. Montelukast is singular. That's the brand name. It does have a black box warning that it should not be given to patients with neuropsychiatric events. That's a common test question because they want you to catch that if a patient has a history of suicide or something like that, then that probably is not the best medication for them. Methylxanthines, most of you are probably very familiar with the class of methylxanthines since caffeine is in the class of methylxanthines, which is helpful to remember that theophylline has all the same side effects of caffeine. It causes the jitteriness, the insomnia, palpitations, tachycardia, hypertension, all of that as side effects because it's very structurally similar to caffeine because they are in the same drug class. And finally, we have the mast cell stabilizer, which is cromolyn. Probably the most tested on point about that is that it's a 4 times a day pill. So that's something that you should keep in mind. But for all of these, there's not a whole lot to add over the RN content, so I'm not going to go into those any more detailed. This chart does not belong to me. It belongs to the Allergy and Asthma Network. This is very, very popular. If you've ever worked or been to a pulmonology office, they pretty much all have this hanging in the patient's rooms. And this goes through every inhaler, both the albuterols, the ICSs, the ICS with LABA, the ICS with LAMA. This goes through everything. LAMA, if I haven't mentioned that previously, is long-acting muscarinic antagonist. The drug that's talking about is tiotropium. I guess I should have put that on the previous slide, is another one of the chronic management medications. Tiotropium is the long-term version of ipratropium, and it's one of the additional medications we have that we can use for long-term chronic management of asthma. We're on to our last slide. A few other things to discuss about asthma. First of all, oxygen toxicity. We know, and I mentioned this at the top of the lecture, that patients can get too much oxygen. Remember, if a patient's blood vessels, they have full oxygen saturation, they have no use for extra oxygen. The oxygen, the O2 molecules break up into O and O, oxide and oxide, and those are called oxide-free radicals, and they are harmful to our organs, so we don't just excessively give patients oxygen if they don't need it. Intubation, I want to be very clear on one thing. Some patients that have severe asthma may end up intubated. Intubation does not solve their problem. Their problem is that their airways are constricted, inflamed, and full of secretions, and they can't pull air in. Intubation doesn't fix any of that. The whole reason we end up at intubation is because of their asthma, because they're struggling so hard to breathe. They just become physically exhausted. They don't have the energy to breathe anymore. They stop breathing, and that's where intubation helps. Obviously, hopefully we get to that before they actually stop breathing, and we recognize early if we're going to have to go down that pathway. CPAP and BiPAP, conversely, these actually can help the patient breathe because these push air into the lungs. So these can push into those pipes that the patient's struggling to fill with air. These mechanical ventilators, CPAP and BiPAP, can actually do that for the patient. This is elementary and more at the RN level, but do remember that it is a standard of care that all patients with asthma should have a written asthma care plan developed with the patient. All patients with asthma should be assessed and educated about their triggers. Almost every patient does have specific triggers that are responsible for their asthma exacerbations. Once they get the hang of that, their life tremendously improves as they learn to avoid those. And finally, if a patient is pregnant and has a history of asthma, please make sure you're managing their asthma. That is vital for the survival of the fetus. Here's the references for everything that was discussed here. If you have any questions, please reach out. Have a great day.